For more than 20 years, women were given one of two messages about hormones. Either hormone therapy was dangerous and should be avoided altogether, or it was the missing anti-aging cure that every woman needed. Neither one of those messages is accurate. The research has changed, but not always in the ways social media would have you believe. Today, we're looking at what truly has changed over the past 10 years, the past 5 years, and the past 1 year in menopause and hormone research. More importantly, we're going to tell you which findings should actually change the way clinicians practice and which headlines are still getting ahead of the evidence. Welcome to Hump Day Hormones. I am Dr. Jill Jennings, a board-certified OBGYN and Menopause Society certified practitioner.
And I'm Courtney Spann, a nurse practitioner. We work at the Women's Clinic in Little Rock, Arkansas, on the campus of Baptist Health. We are here to talk about all things female hormone related, from puberty to menopause and everything in between. We are here to inform you from a medical point of view about the latest scientific evidence in the world of hormones.
You can find us on social media, Facebook and Instagram, as well as YouTube as Hump Day Hormones. And you can email us your questions or topics for the show at humpdayhormones@gmail.com. We just wanted to have a quick little disclaimer that everything we talk about here is for informational and supportive purposes only, and this is not medical advice, as we are not your provider. Your body is unique, and so be sure to chat with your healthcare provider before making any changes to your healthcare routine. Welcome back to Hump Day Hormones. We are doing how menopause care has genuinely evolved over the past 10, 5, and 1 year, and why some people are still stuck in the post-WHI era. So we just want to kind of walk through big changes. I thought this was fun, and this is something that I've just kind of had sitting on the back burner to do for a rainy day, and it is, in fact, a rainy day.
Yes, it is. Much needed rain in our area.
Yes.
Yeah.
I've been so excited about, excited is a weird word to use for this. But the Lindsay Clancy trial, excited seems all wrong there. But we've been sucked in to watching that. And I think it's so relevant because we're moms. We deal with postpartum stuff all the time. And we do have a psychiatrist from UAMS coming on. She runs the women's mental health program over at UAMS, and she's going to come on in a couple weeks, and we are going to have some episodes kind of leading up to that that talk more about postpartum depression. I had an email from a listener. I just kind of want to read some of this because it's so sweet, and we are going to kind of get back to like progesterone, PMS, PMDD, and postpartum depression. I almost think of those things like a continuum in a way because they're all just like progesterone foes.
Yes. And I think that's why I think there's a couple of reasons we have been so sucked into the Lindsay Clancy case is because we are moms, we have kids, but also from like the hormone side of things. I mean, she was 8 months postpartum, and we're like, did anybody ever check your hormones? Not saying that if you did that would have changed the outcome, but like it's interesting to know, could that have been a better treatment option for her?
Well, when they were obviously at the point of like, let's throw it to the wall and see if it sticks with changing medications 842 times. So how about let's just draw some labs? And that girl seemed like she would have done whatever you told her to do. I know she's getting some flack about not being consistent with taking her psych meds, but it's hard to do that when something gives you a weird side effect. Like last week we talked about, some people don't tolerate progesterone well, and you know that pretty quickly after you start it. And so just trying to power through that. Obviously let's like regroup and come up with other options. So hormones would have probably been, at least checking into them would have probably been a good idea. But we got this email and it's from a lady in Oregon. So,
Wow.
That's Bend, Oregon. So, I
Thank you for listening from Oregon.
And like, I want to come visit Bend, Oregon.
Yeah.
Yeah. And she just says a sincere, heartfelt thank you for your podcast. I rely on it for all things hormones and really appreciate your balance of scientific research and anecdotal information. So today is going to be one of these like scientific research ones. She said, plus our delivery is uplifting and doesn't feel dry and boring.
Oh, yay.
So sweet. I know.
Thank you.
So, and then she kind of goes into that she had a hysterectomy last year and kept her ovaries, but that she feels like her ovaries kind of pitched a hissy fit and just she's 46, perimenopausal, and said that she has been able to go in and she comments that her doctors and nurse practitioners are great, but that this has kind of empowered her to go in and feel like that she's be able to have like a more educated conversation about hormones.
Love.
So that's like our whole goal here. And so
that literally gave me chills. That is literally our goal.
Yes.
From the get-go.
Yeah. I just love that. Yeah. You have felt informed and been able to ask questions, but she specifically said at the end that we've mentioned PMDD a few times, and it came up in the episode where we were talking about progesterone last week. And that she personally didn't do well on oral micronized progesterone. And because she's had a hysterectomy, is on a cream and doing well on that. And so she is also requesting a topic on a podcast on PMDD because her teenager struggles with that a little bit. And so, yeah, I do want to, in the weeks moving forward, maybe do some PMS, PMDD, postpartum depression. Like, what are the gold standard treatments? Like, what does ACOG say? And how, like, maybe they got off track with Lindsay Clancy, or did they do it just right? You know, clearly the end result says that we didn't do it just right. But, just kind of walk through some of that a little bit. But today, so the psychiatrist from AMS is coming on. I think we have 2 weeks between this and her. So that'll kind of be in the next 2 weeks what we do. But today we just want to walk through kind of this research and what has changed and kind of gotten us to the place where we can have those conversations. So this is more like evidence rather than kind of advice here. This is just what evidence we have and what has changed. And for some people out there, nothing has changed. They're still telling everybody, what was being said after the WHI, which is clearly incorrect. But so we're just going to go like what's changed broadly over 10 years, then kind of zoom in more to 5 years, then really zoom into the past year. So
love it. Yeah. So over the past 10 years, let's talk about like kind of what has changed. So number one, we stopped treating hormone therapy as one medication. The older conversation was, does hormone therapy increase the risk of breast cancer, blood clots, heart disease, or dementia? The better question now that we ask is which estrogen, which progestin, which route, which dose for which women started at what age.
Yes.
So much more of like a detailed kind of question than like a broad umbrella term of hormone therapy.
Yeah. Like all hormones are not created equal. They shouldn't all be put in one bucket.
That's right.
Current guidance recognizes the benefits and risks vary according to estrogen alone versus estrogen plus a progesterone or plus progestin. So those have different risks. Oral versus transdermal. We did that podcast a couple weeks ago. Dose, so low dose versus high dose. The type of progestin, or if it's a progesterone, those are wildly different. And we've gone over that a number of times. And then the age and time since menopause, like, are you 2 years out? Are you 15 years out? That's a whole different ballgame. And then who you are at baseline is a big deal. Your baseline cardiovascular and blood clot risk and your baseline breast cancer risk. So we all have different baseline risk because of who we are and our family history and all that kind of stuff. But the Menopause Society, so kind of the people that tell us what we are supposed to think about this, the Menopause Society now emphasizes that for most healthy symptomatic women younger than 60, which I'll just stop right there. I disagree. You don't have to be symptomatic. I still think you benefit from hormones.
Yes.
But you're not symptomatic, because some of these things that it helps with, you don't have any symptoms from, like your bone loss. You don't feel that happening. You're clogging up coronary arteries. You don't feel that happening. Things are changing in your brain.
Yeah.
You don't necessarily feel as they're happening. You feel the end result of them. And then all the dementia risk stuff, you don't feel that happening. But anyway, they say for symptomatic women younger than 60 or within 10 years of menopause onset, the benefit risk ratio is generally favorable. So that just means, like, if you're close into menopause, it's more likely than not that you're going to benefit from hormones. So, I mean, that's what that's saying in just short lingo. So what this should change in practice is that people should stop saying that hormones have this universal hormone risk. Like, make them break it down. Like, if somebody says, well, hormones are just risky, like, all hormones are risky, or which ones are you talking about? Which ones do you think I would benefit from, and which ones do you think I should avoid?
Right.
And so we should be counseling patients specifically about the formulation that's being considered.
Yep.
So,
that's exactly right.
So that's been big practice changing, and really should change the way we talk about hormones for sure.
Yes. Something else that has been looked at a little bit differently over the last 10 years is timing. So we know that timing matters, but the whole 10-year rule is not like the end all be all. It is not your brick wall of if it's been 10 years in a day, you can't start hormones. So evidence over the past decade has reinforced the timing hypothesis, which tells us that starting systemic hormone therapy near the menopause transition is different from initiating it for the first time many years later. This initially came out from the ELITE trial in the New England Journal of Medicine in 2016 that compared less than 6 years from menopause and greater than 10 years from menopause, and showed less coronary plaque. We know that to be true as well on bone and brain data. So, I mean, there is evidence to support that starting hormones earlier into the menopause transition has better benefit risk and long-term kind of prevention risk.
Yeah. I mean, that was 2016, the New England Journal of Medicine.
Literally 10 years ago.
Literally 10 years ago.
Yeah.
So, get with it. If somebody's still acting like they don't know some of that, you've had 10 years. I mean,
right.
Come on now. But yeah, so it's not like there's some magical timer that goes off in our body and says, okay, you're 60 or you're 65 and now you need to stop. I mean, what that kind of ELITE trial was saying was just that earlier intervention is going to give you the biggest benefit for protection. But it doesn't mean that at 60 or 65 or whatever that magic number for your 10 years is whoop, all of a sudden it's not beneficial anymore. I mean, that's not what that means.
Right.
It just means that by the time you're 60 or 65, you've likely got a little bit of bone loss that's already happened. You lost 20% in the first 5 years of menopause. So you've got bone loss that happened. You've got built up plaque in your coronary arteries because, you're older and you've eaten more McDonald's and you've whatever you've done to build up that coronary plaque. But I mean, you've got that at that point, just more of it. And so in the Women's Health Initiative study, again, remember they were using oral hormones and it was a conjugated estrogen, not estradiol, and it was a progestin. And when they started these women that were over 63 in the study, they had increased risk of blood clot and stroke. Again, oral estrogen. So you can't take that same principle and apply it to a transdermal, and you sure can't take that same principle and apply it to a 50-year-old or a 63-year-old who's perfectly healthy with a clean coronary calcium score. I mean, so.
Yeah. Once again, I mean, I'm sure y'all have caught on every person is very different. And this is a very individualized approach.
Yeah.
And I've seen women that are 70 before and they're still having hot flashes, and I mean, even that is just a whole conversation alone about their risk, benefit, all of that kind of stuff with hormone therapy.
Yeah. I mean, I think that we just really have to go back. Again, that was number one on this list, and individualize the therapy. I'm not saying, everybody just go get on it. But the other thing, I mean, that really evidence came out because of blood clots and stroke. But those things in the studies, if you look, are more likely to happen in the first 1 to 2 years that you start a hormone. And so if you started your hormones when you were 52 and you're on, I mean, I don't even care. It is Prem-Pro, let's just say. And you started it at 52. If you were going to have a stroke or a blood clot because of that, you probably would have done it back then. It's not like magically now going to happen because you've been on it for 10 years.
Right.
You know, so you've kind of almost done a challenge on your body and shown that that's not going to happen. But so, I mean, all this to say, we don't need to just take a stable patient on hormones who's otherwise baseline healthy and nothing has changed, and all of a sudden rip their hormones away from them because they're 60 or 65 or 70 or whatever this magic line in the sand is.
Please don't do that.
Yeah, it just needs to be a conversation. I mean, maybe their formulation needs to change. Maybe they need to switch to a transdermal. Like, just reassess, like, why you're on it, whether you're still getting benefit or not. Do you still need it? What are your cardiovascular risks at this exact moment? Because they're going to be different than they were when you were 50. And then, reassess, like, what dose, what route, those kinds of things. So, but the Menopause Society states that there is no universal age at which hormone therapy must automatically be discontinued. So it's not some line in the sand. And if a PCP is listening to this, please stop telling patients that. Like, stop saying, like, okay, you're 60, it's time to stop your hormone now.
Yeah.
Because then they end up in our office or somewhere saying, somebody told me how to stop this and now I feel like complete dog poo.
Yes, yes. And back just fully symptomatic and all the things.
Yeah.
Yep. Okay, the next one is GSM, so genitourinary syndrome and menopause. It has now become a chronic medical condition and is not just called like vaginal dryness or vaginal atrophy or senile vagina or whatever the initial terms for it. So we now recognize GSM as a progressive condition affecting the vulvar and vaginal tissue, sexual comfort, urinary urgency and frequency. So lots of bladder symptoms, recurrent UTIs, pelvic and urethral symptoms. So what we know now is vaginal estrogen cream is first-line treatment for those.
Yeah, I mean, just literally with reckless abandon, just give it to anybody. Just literally everybody.
I mean, you're not going to do wrong.
Yeah, I mean, unless they've got some fungating tumor growing off of their vagina. Look at their vagina. But I mean, almost. I mean, I'm sure you can find the 0.1111. Or what am I trying to say? 0.0001% person that it's not.
Yeah.
But literally almost everybody. And it will always in my mind be credit to Rachel Rubin.
Absolutely.
Yeah, she's just been a moving force in getting this out there, getting the word out there, and then doing the actual research. So it was a 2026 study by Rachel Rubin. It was an observational study, but it looked at over 1.8 million women. I mean, that's insane.
Huge.
Not all of them were on vaginal estrogen, but in that, some were, some weren't. But they showed a 50 to 80% lower odds of sepsis in women, from urosepsis kind of thing, a 40 to 70% decrease in hospitalization. It's one of the number one reasons women get brought from a nursing home is a UTI, and a 60 to 80% decreased risk of death, that you're going to die from your urosepsis. So, I mean,
12.
That's insane. And I mean, we're still in the 10-year section. So I'm saying that was a 2026 study, but we have a study from 1993 that showed that vaginal estradiol decreased recurrent UTIs. It went from 62% in placebo to 16% in vaginal estrogen. So this is not new news that vaginal estrogen is good for prevention of UTIs or vaginal dryness or that kind of thing. But I think what has changed, probably because of Rachel Rubin and Kelly Casperson and all of them, is just that it is more recognized. It's not just your vagina. or your urethra. I mean, it is your entire bladder, your entire pelvic floor, the muscles and the blood flow and everything, down there. Like, it's a whole system. It's not just like a vagina that's made for having babies and sex.
Amen. Yes.
Can y'all tell I'm coming in hot this morning?
I do think that like PCPs and other providers are really picking up on this, probably more so over the last year since the GSM guidelines came out last June 2025.
Mm-hmm.
I have had so many women that vaginal estrogen will be on their medication list. And I'm like, oh, yay. When did you start this? Who started you on this? And they're like, well, my PCP did because I kept having UTIs. I'm like, oh, praise the Lord.
Praise the Lord.
Thank you.
And like, literally, I think the cool thing about it, is that we don't have to be scared of it. You don't systemically absorb it. Your estrogen level's not going to change. So like, you don't even have to be educated on the fact that like, okay, well, I'm scared if I give this woman estrogen, she's going to get breast cancer. Like, I mean, no, that's not true. But even if you don't have time to understand all that, just understand you're not systemically absorbing it. It's not getting into your blood. So even if you buy all these old assumptions that estrogen's dangerous, well, this doesn't even get into your bloodstream because of that. You don't even need progesterone. So you can have a uterus. You don't have to oppose it. So that's what I mean. Like, there's literally, hardly anybody. I mean, unexplained vaginal bleeding or like not doing an exam on somebody, I think is a reason not to start it.
Yeah.
Like, you do need to look at someone's vagina, ideally before you prescribe a vagina medication. But but other than that, I mean, I literally think it's everybody. And I mean, if you want to, you can rub it under your eyes and on your hands. It's good for collagen and wrinkles too.
That's right.
Yeah.
That's right.
So I think a big thing that needs to change in practice is we have to ask. Like, we have to ask the questions. Do you have vaginal dryness? Do you have pain with sex? Do you get frequent UTIs? And so, you can't sometimes wait for women to volunteer that information because it's embarrassing, but it should be something that we are comfortable. At least, I mean, I'm not saying your family practice doctor, but at least your gynecologist should be really comfortable asking you those kinds of questions. And then we also have to change that. We don't just give somebody this tiny tube of vaginal estrogen and tell them just to use it till they feel better. We have to understand that this is like a chronic, like you're never going to have more estrogen.
Yeah.
I mean, unless you're taking systemic. And then sometimes I think we get that like from the inside out phenomenon. You've gotten your systemic estrogen levels up. And so maybe you don't need vaginal estrogen as much, but some people continue to need both. But if vaginal estrogen is going to be helpful, it has to be used regularly. It's not just like amoxicillin that we used it and fixed it and we're done.
Yeah.
I mean, it's a, constantly 2-3 times a week, you've got to be using your vaginal estrogen. So we think of it like we think of our face creams that we put on at night to prevent wrinkles and try to make our face stay young. This is for your vagina in that same vein.
Skincare for the pelvis.
Yeah, everything in the pelvis. You don't just get to like rub some skin cream on your face for 2 weeks and your skin is beautiful. We all know that's not how that works.
This is like long-term stuff.
Yeah.
And it's cheap. I mean, it's easy to do.
Yeah, if it's not cheap at your regularly your regular pharmacy. If it's not cheap there, then we'll hit up Mark Cuban.
Yeah,
because he's got it for $13. So
that's right. Yeah, don't pay more than that. And if it is, yeah, we'll handle that for you.
I'll call Mark myself. I'm just kidding. I don't know him like that. Okay, 5 years. We're moving forward. We're 5 years. Vaginal estrogen has become a realistic option even for breast cancer survivors. So we were just talking about how good it is, and we've kind of known that for a long time for everybody, recurrent UTIs, all the things. But breast cancer survivors, this is kind of a new one. So for years, women with a history of estrogen-dependent breast cancers were told that every estrogen, just like anything that has estrogen, is forbidden. Just nothing, no hormones ever. And I think really tables are turning there a lot because we're starting to say like, well, what about testosterone? Or what about, this vaginal estrogen that's not even going to absorb into my bloodstream? Like, how could I possibly stimulate a breast cell estrogen receptor with a vaginal estrogen product? So now the evidence and recommendations are much more nuanced than that.
And ACOG has said that after non-hormonal treatments are unsuccessful, which
come on now, ACOG.
that ain't gonna take long.
I know. And they do. I feel like they still feel like they have to say that. Like, you got to try some lubrication and coconut oil, but that is not changing any kind of architecture.
Literally. So after that's unsuccessful, which that's going to take like a week of, okay, that's unsuccessful, move on. Low dose vaginal estrogen may be considered following a risk benefit discussion. I feel like they're saying that just to cover their butt, but it's like their butt doesn't even need to be covered with vaginal estrogen. I think this will eventually, that statement will be changed eventually. But also, this is an ongoing conversation and like a shared decision with the oncologist as well. Like, you don't want to be over here doing a bunch of hormone stuff on a previous breast cancer patient and their oncologist is not on board. I mean, there are times where maybe you provide the GSM guidelines or recommend that they look at those, if they don't already know them. But yeah, I think you don't want to be stepping on their toes either.
Yeah, and it's not the oncologist's job to be the most up to date with the vaginal estrogen recommendations, right? I mean, that's not fair. That's like you bringing your chemo plan to me and asking me, am I on the right chemo? I mean, I don't.
Yeah, literally don't know.
I literally don't know. And that's why you have your oncologist. But there was a 2018 American Society of Clinical Oncology guideline. So again, like when you're reading the journal that comes out and you're an oncologist, this was in there in 2018, but you may have kind of turned the page because you were more interested in some actual oncology thing a couple pages down. But they specifically stated that low dose vaginal estrogen may be considered in symptomatic women with hormone receptor positive breast cancer who fail conservative therapy. Again, that won't take long, following a discussion. So, I mean, I think it's there. They have that same guideline, but they may not know it, and that's okay. It doesn't mean they're a bad doctor. If they're even willing to have this conversation with you, then they're a good doctor and they do care. And I know that one of our doctors is married to an oncologist here in town, and she's like, I talk to more people about their sex life and their hormones than I really want to, because she's having those conversations. Like, and she is kind of, she's like admits she's not going to be the prescriber of the hormones, which is totally fair. But knowing that they can at least have those conversations and know where to send people is really valuable stuff. So I think we got to stop saying you had breast cancer, so estrogen is never an option. Again, like, let's be more nuanced with our recommendations there. So
that's right. Okay, the next one, something else that has kind of changed over the last 5 years, testosterone. Testosterone finally received evidence-based boundaries. So the 2019 Global Consensus Position Statement and the 2021 ISSWISH clinical guideline clarified that the best supported indication for systemic testosterone in women is hypoactive sexual desire disorder after a proper biopsychosocial assessment. So they're basically saying testosterone can be used after you fully assess the patient and they have low libido.
That's right. And so, what we know now is that it helps with a lot of things, but it has not been like adequately proven. But we hear this all day from patients that it works for fatigue, brain fog, depression, helps your metabolism with that muscle loss, weight gain, dementia preservation, bone loss. And then we also don't have a written in stone, like, what number should my estrogen be, or not estrogen, testosterone, we have that number. What number should my testosterone be, and like, where do you consider it low? So there's no like validated testosterone cutoff that you use to diagnose hypoactive sexual desire disorder. It's literally like, I don't care as much about having sex, and I want to care, and I want to have more sex.
Yes.
Like, I want to care.
Yeah. And the whole conversation around it, like we've talked about before, like women's desire is like biopsychosocial. So,
Yes.
I mean, you have to be like in a good, loving relationship and all the things. And then, just that like desire part needs to be like turned up a little bit. So there's so many other factors that play in, and you can't just like throw testosterone at somebody who's in a crap relationship and expect it to like, cure all the things.
Or their vagina is dry, they've got vaginal atrophy, or they haven't slept in 4 months because they wake up at 2 a.m. because they need some progesterone.
Yeah.
I mean, like, you've
got
got
to have that conversation with everybody.
You got to fix the baseline things. And then I do think of, this comes from Heather Hirsch, but I think of testosterone as like the cherry on top of your ice cream sundae. So,
yes.
Some people need it, some people don't.
Yeah.
Yeah.
Yep. And it's so different for everybody. I mean, there's women that are like, oh my God, it changed my life. And other women, they're like, I can't even tell. And I'm like, well, it's okay. Then I don't have to keep using it.
I mean, what I say to people all the time is like, I will and probably could, if I had the time, sit here and talk all day and argue with whoever I need to that estrogen is necessary. Like, you need estrogen. Like, we truly have the data that you will have less comorbidities, you will have less heart disease, less diabetes, you will live longer. Like, we have that data written down if you take estrogen. We do not have that data with testosterone. So, I mean, do it if you want. It may be helpful for a long list of things, but we don't have data that says you're truly doing yourself a disservice if you don't take that. And that we do have that with estrogen. So, cherry on top.
That's right. So what should kind of change in practice involving testosterone is you don't treat a lab number. You diagnose the clinical condition, you address all the other kind of cofactors like contributing medications, relationship factors, pain, GSM, mood, sleep, other health issues. And then you consider physiologic dosed transdermal testosterone when appropriate.
Yeah.
And then you have to just, monitor for benefit, adverse effects, if your levels are getting too high. So there is some monitoring that goes along with it.
Because, people absorb this stuff at all kinds of different levels. I'll tell you that. I mean, and compounding is big in the testosterone space because we don't have a lot of, FDA. We don't have any FDA approved female products. So we're either hacking our way through male stuff, or some people want compounded. And I'll say that gets a little wild sometimes with trying to predict what somebody's level is going to be, because it's like, what compounding pharmacy did you use? I mean, like, what's going on? So
it's so variable.
Yeah. Okay. Okay, next, this one has changed in the past 5 years. By the speaking of compounded bioidentical hormones lost their scientific marketing advantage. And I think that's because people got educated and realized, like, hey, wait a minute. Estradiol is bioidentical, and micronized progesterone is bioidentical, and testosterone is bioidentical. Like, I don't have to get it compounded to be bioidentical. So I think, I really think the compounding stuff sort of, made its headway whenever the WHI made everybody feel like that hormones were unsafe, and that was synthetic hormones. And so compounding came out with like, ooh, look, we have this like bioidentical options. Well, I mean, we have bioidentical FDA approved options too. So you don't have to get it compounded. And ACOG actually recommends FDA approved formulations, which, let's be really honest, that ACOG and the FDA are kind of all in bed with the government, and they're kind of all getting funding from the government. So without being a giant conspiracy theorist, of course they're going to agree with each other. They're funded by the same sort of people. They've got money coming through the same funnel.
Yeah.
And then, I give some money to ACOG, but my $100 a year, or whatever my dues are, 250, I don't know, it's probably not enough to give me a lot of pull, right? And so ACOG is going to listen, obviously to some of their biggest funders, but ACOG and the FDA, are all kind of in it together, and ACOG recommends FDA-approved formulations over routinely compounded menopausal hormone therapy when approved options are available, like which we just said they're available in all hormones. So, and I don't think compounding is innately bad. I don't. I think you need to know you don't have to do that.
Right.
Because compounding is expensive.
Yeah.
So
there is a time and place for it, So if you have like an allergy to an ingredient, if you have an allergy to peanuts, then you, cannot take oral micronized progesterone because it's made with a peanut oil. So we can get that compounded. Or if you just require like a specific formulation or dose that's not commercially available, those are kind of the times and places to use compounded options. There are some really cool things like troches and like combo creams and stuff like that can be compounded and used. That's usually not like our first thing that we're going to go to. We're probably going to try like commercially available stuff. Honestly, because I'm cheap and I think about the cost of things. And if you're going to do, take your hormones for a long time, you have to look at that, I don't know that I want to be paying $50 to $100 every month if I don't have to.
Oh, no. Apparently it's a big legal thing that you are not supposed to, as a medical provider, counsel patients on cost. But I'm like, I do that every day because
everybody asks how much is it going to cost because they think hormones are expensive.
But it's not ever supposed to come across that you made your medical decision for a patient because you thought they either could or couldn't afford something. And it's like, well, come on. I don't go shopping, at the grocery store or for clothes or anything and not know how much something's going to be.
Yeah.
You have to, that's part of the decision making. Am I spending $500 a month on this stuff or am I spending $25? Because, that's just, everybody has a budget. So I think that's a little ridiculous to say that we don't include price in our counseling.
Well, and I think that has to do, you have to think about the patient's compliance. If you're recommending some, compounded cream of whatever and whatever.
Yeah.
And they can barely pay their rent or they rode here on a bus because they don't have a car. I feel like, I don't know, that kind of goes into, it's just like that. It's just a whole person, conversation. We're trying to take care of the whole person.
Exactly. Okay, so now we're down to just what has changed in the past year. I think this is cool. I think it's cool we work in a space where things are changing in the past year. In November 2025, the FDA announced that it was removing several broad class-wide boxed warnings. Obviously, they had needed to be removed for a really long time. But I think we've finally had enough squeaky wheels with Kelly Casperson and Rachel Rubin and kind of these really big names in the hormone space, and enough, basically enough squawking people talking about it that they finally listened. So those were removed. 3 big targeted areas that were removed were the boxed warning used to say that you had a risk of breast cancer, cardiovascular disease, and there was a big broad kind of language around MI, so myocardial infarction or heart attack, stroke, thromboembolic events, clots, and cardiovascular outcomes. And then literally the boxed warning used to say probable dementia, not just dementia. Probably you're going to get this if you use these products.
So wild. And it didn't matter if that was an estrogen pill, patch, vaginal cream, anything with estrogen in it had this warning on there.
Yeah, which is, now we know just straight up not true. And it may be actually the reverse of what is true. But anyways, the FDA specifically said that those old warnings were being removed and that they were derived and applied from the WHI, and they were too broad across different ages, formulation routes, timing, blah, blah, blah. The one thing that they did not remove was the endometrial cancer warning. I mean, that's just got to stay. That is completely biologic. If you take systemic estrogen and you have a uterus, you have to oppose estrogen on the lining of the uterus somehow. The most common way to do that is progesterone, but there are other ways. But and so what that changes is it validates what menopause specialists have been arguing for years, and that risk from the older WHI regimens can't be just like straight up applied to what today's regimen is. But it doesn't mean that hormone therapy is risk-free, appropriate for everybody, that it prevents every single chronic disease, and that every single person should be on it. And it definitely doesn't mean that we get to stop taking progesterone when we use estrogen. But again, I feel like there's a common theme here. What it does mean is that we need to update our consent conversations about who you are, what your formulation is, and what your risk is.
That's right. Once again, super individualized.
Yeah, like
about all the things.
We are the box now. No big, black, scary box, but that leaves us as being your box to tell you what your risks are. I mean, somebody's got to tell you specifically what yours are.
Yeah. Okay, so the next one that has changed over the last year is we have new targeted non-hormonal pathways for hot flashes specifically. So the emergence of these neurokinin receptor antagonists have changed the understanding of vasomotor symptoms. I don't know how to say the generic.
Vezolinolent, or I don't know. Veoza and linquit is the other one.
So cute. Yeah. So they're the first FDA-approved neurokinin receptor antagonists for moderate to severe menopausal hot flashes. They target that thermoregulatory signaling and act different than a hormone or like an antidepressant. So these can really be so good on somebody that can't take systemic estrogen, like if they have an active cancer.
Or there are
they just don't want to.
Simply do not want to. Like, I am terrified. My mother died of breast cancer, and you will never convince me that it wasn't from her hormones, and I do not want to take them. It's like, I mean, if you are on that hill and I can provide you some information about why even in the WHI we did not think estrogen caused breast cancer, and you still are just like, I do not want it, like you've been counseled appropriately, but you simply do not, then that's okay. And like, well, just you don't have to suffer with hot flashes. These medicines are not going to treat anything besides your hot flashes. They're not going to help your bones. They're not going to help your cardiovascular disease and blah, blah, blah. But they are going to help your hot flashes. And I mean, there's other things that you can do for hot flashes too. So that was like Paxil, gabapentin, clonidine. But some people can't or don't want to take those either. So this is kind of a new thing that we have in practice. It is cool. It's cool that we can like get down to the neurokinin receptor, that thermoregulatory. I mean, it's cool that we can target something so specific. There is some safety considerations with Veoza as far as the liver goes. So you do have to monitor liver functions like before you start, after you start, and kind of like every 3-month increments. So, I mean, it's a very cool, it is not completely risk-free, as nothing is. So there's just some considerations to take in for that. Yeah, and I feel like this last big change that has happened over the past year is everything that we've been saying at the end of every one of these recommendations, that evidence is pushing us away from age-based rules and towards risk-based prescribing. So the newest international guidelines continue to emphasize individualized decision making. Like that's just what we keep saying over and over again. So rather than rigid rules based on age, duration, or a single risk factor. So the newest model asks, what symptoms or indication are we treating? How severe is it? What are the baseline risk for cardiovascular and clot? Do you have a uterus? Do you need systemic or local therapy? Is transdermal therapy preferable? Do you have a personal history of breast cancer? What do you value the most? Is it your lifestyle and the way that you feel and the way that you sleep and your mood and your sex life? Or is it, I'm so scared of hormones, I don't want to use them? I mean, or what is like your most thing that you value? And then are we continuing treatment past a certain age, or are we initiating it late? I mean, those are all things that are like, okay, and on the table and acceptable conversations. You're not like on fringe medicine by doing those things at this point. Those are all well supported. So
yeah. So kind of what should change in practice is there's not an automatic yes or an automatic no with hormone therapy, and to use basically a risk stratified indication based treatment plan. So very individualized.
I'm really sorry, like, if somebody wanted this to be easy, if somebody wants the hormone playbook and wants it to be easy, because it's just not. I mean, it's not going to be you. If you want to go into hormone practice, but you really don't like sitting down and talking to people, then you just don't need to go into hormone practice. Because, I mean, it's a lot of individualized conversations, which is going to require getting to know your patient. And, more than just some checky boxes, which, why does, like, everything reminds me of the Lindsay.
Oh my God, everything.
Because.
Oh, you just click the box? You just check the box?
Did you know your patient? I know.
I would be scared if Kevin Reddington was coming after me.
I know. My goodness. I'd just crawl underneath that witness stand. I would have just crawled under there and started crying, probably.
Absolutely.
So, okay. Let's talk about, we talked about all these things that have changed over all the years, but what has not changed? Like, where are we still a little bit kind of stuck, and we don't have enough, evidence that we have to change or alter our practice. So we still do not prescribe systemic hormone therapy solely to prevent dementia, cardiovascular disease, weight gain, general aging, or every chronic disease associated with menopause. So if, it's not like you feel fine, you're sleeping well, you have no hot flashes, life is just in general good, well, you should still take this estrogen to prevent cardiovascular disease. I think that's kind of true. And I think that we will get there, but it is not an on-label indication. You are still a little in the fringe if you're saying that. So I'll admit it. I live in the fringe, but that's our job. I mean, that's, but usually, I mean, people have some other, on-labeled indication. I mean, hot flashes, night sweats, GSM.
Prevention of osteoporosis.
Yeah. I mean, that's everybody. So everybody has an indication, but these are just not labeled FDA indications.
You can't say, I don't want to get dementia, so let me start estrogen. You can't say that. Yet.
I think we will be able to someday, but.
Yeah, I do too.
Yeah. Hormone therapy can favorably affect certain symptoms and physiologic systems, and it does prevent bone loss and fractures while being used, but it is not a universal longevity drug. I mean, that's just an annoying statement. Like, aging is inevitable. Hormones are not going to prevent you from aging. Like, some people think hormone replacement therapy is like, oh, I'm going to feel 25 again. No, you're not. Like, you're not. I mean, no 55-year-old's going to feel 25 again.
Right.
And we're not trying to make your hormone levels what they were when you were 25 either. We're just trying to give you enough to protect those long-term things. So it's not like replacing you to those levels and trying to make you or your muscles or bones or whatever that age. So, obviously, that to me, that's such an obvious statement, but I feel like, it needs to be said for other people. But the FDA and major professional statements continues to support menopausal hormone therapy. is primarily for vasomotor symptoms, GSM, premature ovarian insufficiency, so going through menopause early, prevention of bone loss. Those are our FDA Holy Grail government funded recommendations.
Yeah. Yeah. And I mean, GSM, if you don't have anything else, like you don't have hot flashes, you don't go through menopause super early, you don't have a family history of osteoporosis, GSM is coming for you, girl. If you don't have some kind of estrogen, whether systemic or local, you can't run from that. It's coming. It's coming. Okay, so unfortunately, we still do not have evidence that every woman needs testosterone. We still should not use hormone levels alone to diagnose perimenopause. You have to listen to symptoms along with checking other labs.
It ain't a checkbox. Jennifer Tufts ain't going into this.
We still need adequate endometrial protection when you're using systemic estrogen and you have a uterus. And we still must evaluate unexplained postmenopausal bleeding.
I think the title of this episode should have been "It Ain't a Checkbox."
I love that.
Which should have
checkbox.
It should have been. So the biggest change in hormone research is not that we discovered that hormones are completely safe or that we did away with the old adage that they were completely dangerous. So it's not like we've had some big bam thing happen. It's just these slow things over time, and that we have finally moved beyond treating hormone therapy as one drug with all one risk profile. We now have multiple different hormones, and we have multiple different women with multiple different bodies and multiple different symptoms. And
multiple different conversations to be had about all of those things
all day, every day. But good menopause care is individualized. And so somebody coming at you with a big, broad statement, you need to make them specify that a little bit. So the question is no longer simply, is hormone therapy good or bad? Yikes, that's a really loaded question. The better question is, for women, for this indication, using this formulation, do the expected benefits outweigh the potential risk? So it's a harder conversation to have, but it's the one that we need to have. So this is what evidence-based, patient-centered menopause care should look like. And that's what fires me up. That's what gets me going. That's what gets me up here on my day off, yakking on this microphone.
Yes. Well, and just like that email that we read at the beginning, all of this care, hormone care, menopause care, I mean, it involves the patient and all of her things that come along with that. It is not us saying you have to do this, this, and this. No, it is a very open conversation, individualized to her with all of her risk, lifestyle, all the things.
I love when patients say, what do you think I should do? I'm like, oh, okay. Because some people are like, don't make me help you make the decision. Just tell me what you think. And I will, after I look, at your story and your labs and hear your symptoms, I will tell you that. But, sometimes we'll say you could do this, this, or this, and we'll kind of let you help pick. But some patients, they're like, I don't know, that's why I'm here. You tell me.
Yep.
And so we're happy to do that too. So
yes.
Follow us on social media. We're on YouTube, Instagram, Facebook. We're not on TikTok. I still don't feel like I don't know if I can handle just one more thing right now.
I know. I don't even have a TikTok. I don't know. I feel like I kind of missed it. I feel like I'm too old. I don't know. But everybody loves TikTok.
I know. And then if I had one more thing that I was sitting there scrolling at night, I don't know. I would say that we'll get one someday, but I don't really know if we ever will. So follow us on the other social medias that we do have. Email us your suggestions. We're Hump Day Hormones, all one word, at gmail.com. So email us your suggestions. We are going to take the suggestion that we had from Bend, Oregon, and we are going to have some PMS, PMDD, a little bit more about progesterone, postpartum depression treatment sprinkled over the next 2 episodes. And then we are going to have Dr. Griffith from UAMS Women's Mental Health Clinic coming in mid-September.
Yes, I'm so excited.
Y'all, it's day 19 of the Lindsay Clancy trial. I think they're going to give closing statements. Y'all tune in, go listen. I mean, if you like don't care, hate her, think she did it, or if you think her husband did it, or I mean, none of that really matters. At this point, I think we are moving the needle. We're talking about postpartum depression and it's becoming center stage. And I mean, Big Red is amazing. So just go listen, learn something about why we should care about postpartum depression, why we should even know what postpartum psychosis is. And we will see you next Wednesday. Okay.
Bye.
Bye.